for treatment of hyaluronic acid filler induced vascular complications. So I will tell you about it. So this is that's it's from American Society Cosmetic Data Bank that botulinum toxin and hyaluronic acid fillers is getting more and more to the doctors. And as I wrote 6 articles about Doppler ultrasound. So I'm using Doppler ultrasound these days to see the artery first, and then I detour the filler injections. So that this is one of the I think this is one of the very important thing for prevention of the vascular complications. And right now, lots of doctors from all over the world is.
Hello, everybody. Today I'm going to talk to you about avoiding intravascular complications. I'm Greg Goodman. Got no conflicts for this lecture. Vascular anatomy avoidance is first rule is that vasculature is everywhere and there's only relative safety. Are needles safe everywhere after I know my anatomy? Certainly not. Anatomy knowledge helps, but it's not completely safe, doesn't make it completely safe. 62% of trainers in a survey we did some years ago, for 11 years experience for most of the trainers plus, and 62% have had at least one intravascular event. So experience is not everything, and don't just think because you know stuff that necessarily you're going to stay out of trouble. There's infinite variability within the layers, but within a layer, but not necessarily so much between layers. If you look here, for example, this is a facial artery, but it's not taking the usual course of facial artery. It's coming along with the superior labial artery and then taking it.
I've done it right. Okay, thank you. So with your permission, Dr. Han, I changed the title from how I avoid vascular to how I try to avoid vascular complications. This is because it is practically impossible to avoid them completely if we work long enough. Maybe I'm too severe, but I do consider even as normal hematoma with no consequences, I consider it a vascular complication. Why? It's a complication because we don't want it to happen and it makes patients miserable. Now, the way we try to avoid venous problems basically should be the same way we also avoid other vascular problems, and I'll explain this. This is usually how every lecture starts, and this is unfortunately how
that I see such a high proportion of doctors while attempting aspiration, they did it just wrong. So before filler injection, we pull back the plunger, we wait, and we see if there's blood coming back. And it's been sometimes criticized to be not effective or not necessary. So so far in those published in vitro studies in which they looked into how different filler products are successful in aspiration, whether they are effective for aspiration. And most of the conclusions were that because of the possibility of false negative results, which means that even if you don't see blood upon aspiration, you cannot rule out the intravascular positioning of the needle 100%. So they don't recommend you to use aspiration as the single sole only method to avoid danger.
We did in vitro test and the in vivo test, which is a rabbit test, and this is primed with nothing. And this is primed with normal cell line, and this is hyaluronic acid filler. So that some doctors inject fillers, and then they remove it, and then they inject again, and then aspirate. Even though inside the needle priming is hyaluronic acid filler, then it has a lot of false negative finding. So what was is that inject before priming is normal cell line, or that's nothing, is very important for us, for our finding. Yes. So we did our in vivo test also, the same result, and priming inside is inside the needle is very important for aspiration test. So that was our.
Okay.
I studied a lot about retrobulbar here in eyes, and oh, it was so difficult to make blind of the rabbit, and I couldn't do it anymore. And yes, that is.
So that also means how capable the injectors are, because we make so many patients blind, right?
Yes, it's a very difficult job actually, but it happens, it happens all the time. It's just a disaster.
Okay. So
do we still have time for one more question?
Oh yes, please.
Yeah. So, I would like to ask the experts about the experience or opinion of venous embolism, because so far we have seen only very limited description of that. We know that it's more subacute in presentation. You may not see the blanching, or it may be milder in presentation, but in practical sense, or in daily practice, how do we differentiate arterial versus venous embolization with confidence, and do we need to? And